So good evening, good morning, or good afternoon, depending from where you are joining us tonight. Tonight, the IVPN NeuroPsychiatry is organizing the second Migraine Masterclass in collaboration with the American Association for Migraine Disorder, supported by Pfizer, our sponsor. So before we start our webinar, I would like to introduce for you tonight our moderator, Dr. Muhammad Harib. So Dr. Muhammad Harib is currently a consultant in neurology in the American Center of Psychiatry and Neurology in Abu Dhabi. And Dr. Muhammad Harib, he's a consultant neurologist who has a very deep experience in adult epilepsy. Dr. Harib works with adults with headache, Alzheimer's disease, and cognitive impairment, multiple sclerosis, peripheral neuropathy, radiculopathy, Parkinson's disease, cerebrovascular accident, depression, and anxiety, in addition to Botox injection for migraine headache and performing and reading EEG, CNS, and EMG. He completed his residency and epilepsy, his neurological residency and epilepsy fellowship with clinical neurophysiology at the American University in Beirut, and he obtained his residency in internal medicine also from the same university. So before giving the floor to Dr. Harib, let me again thank our sponsor Pfizer for supporting this educational activity and our collaborator, the American Association for Migraine Disorder, for this very fruitful collaboration. Welcome, Dr. Harib, and thank you for accepting our invitation and being with us tonight, and the floor is yours.
Thank you, dear Maya, for this nice introduction. It is my honor to be in this amazing migraine masterclass, which is done in collaboration with migraine disorders. Again, I want to thank Pfizer for supporting this educational activity. In this event, we have two distinguished speakers. The first speaker is Dr. Hiba Bani Hani. She is a registered pharmacist with over than 20 years of experience in pharmacy and healthcare. In addition to her Bachelor of Pharmacy, she got an MBA in Healthcare and Life Science. She started her career with pharmaceutical industry when she held multiple sales and marketing positions for GSK, Allergan, Boots, and other across the Middle East, North Africa, Malaysia, and Switzerland. Dr. Hiba is very active in international organizations. She provides the education for pharmacists in all stages of learning, delivering headache and migraine education through many associations in Canada, United States, and around the world. Dr. Hiba, most welcome, and the floor is yours.
Thank you very much, and thank you IVPN NeuroPsychiatry and the Association of Migraine Disorders for organizing this event. This is the second time I joined IVPN. I think I had so much fun the first time that I was very happy to be invited again. Today, the subject I will be talking about is triggers and lifestyle management, possibly something that is very close to pharmacists' hearts and also practice, but also is something that everybody who's working with migraine faces every day when you see a migraine patient. So I will start my presentation. It is going to be very simple in terms of what we are talking about, but I'm very happy to take your questions and answer your questions after the presentation. I think there's a Q&A section. Please drop your questions and I will try to get to them as soon as I finish. So when we talk about triggers and lifestyle, the first question that I get is, what is a trigger? We know there are symptoms. We know that migraine does not hit suddenly. There's always things that happen before. There are a lot of symptoms that patients feel or experience before the migraine, sometimes 48 hours before an actual migraine attack. So a trigger is something that is either endogenous or exogenous. And these are things that actually make it more possible or reduce the threshold of a migraine attack, but only in those predisposed to migraine. So an endogenous agent, for instance, is menses. Not everybody who gets menses does get a migraine, but if you do have migraine or you're predisposed to migraine, that is something that can actually bring it on either faster or more acutely. Exogenous agents are something like red wine, a drop in barometric pressure, food, stress, and we're going to talk about exogenous more than we're going to talk about endogenous today, but I will also allude to why it is important to look at things that are endogenous. So the first question we have, are there any differences in triggers? Are the same triggers that can trigger a migraine in women is the same as men? Of course, hormonal differences are the first one that is different. So there are gender differences, but they're mainly because of the hormonal differences. In one of the studies or one of the reviews that were just done and published in Cephalgia in 2021, they found that sex hormones differentiate between males and females, and they contribute to a different fluctuation in neuronal brain excitability. That actually affects your internal threshold or the patient's internal threshold, and that leads to an increased potential of an external trigger to provoke a migraine in women. Why do we know that it's hormonal, that hormones do change that threshold? Is because at menopause, we found that the total number of trigger factors that are reported by postmenopausal women and that have already stabilized their sex hormones are very comparable to those in men. Now, a study again that was done, or a cross-sectional study that was again published in Cephalgia in 2021, tried to study what are the most common stressors or triggers, and that was like the biggest in the world. There was around 7,000 patients, more females than males, as you can see, but that is also because of the distribution of the condition, where more females live with migraine than males. Number one was stress. No surprise, a lot of our patients tell us that when stress is more, it's more likely that they're going to have the worst migraine of their lives. Like the more stress you have, the more likely you are going to have a migraine, and the more likely it is going to be worse than other migraine. Migraine by itself causes stress because of the unpredictability. We don't know when it's going to happen. So that actually leads to increased stress triggered by migraine. Is it a causative, or is it a relative, or is it, there is a very, very clear link between increased stress leading to worsening of migraine or causing a migraine to come on. Hormones come next or second, then missing a meal, hunger, and fasting. We're going to talk about this because of all these new trends that we have now with intermittent fasting. We know that we're hearing more and more about more people doing a lot of longer periods of no food, and we see that this is actually a big contributor to, or a trigger for migraine. Weather changes, for a long time people were saying no, that doesn't happen, but now we know for sure that almost half of our patients do get a migraine with weather changes. Sleep disturbances, another big one, again, half of our patients. Perfume or odor, and that is something that is very interesting because now we know that there's more to the pathophysiology of migraine that might explain why perfume or odor might trigger a migraine. Neck pain, another big one, light, alcohol, smoke, sleeping late, heat. So sleep disturbance is 50%, and sleeping a little bit later is another 32%. Heat, food, exercise, and sexual activity, 5.2%. Now, how many triggers do we know? We know that in self-reported by patients, we have 68,000 different types of triggers reported by people living with migraine and who use an app. It's called Migraine Buddy. They have around 3 million users. And of these 68,000 different types of triggers, 2,600 are recurring triggers, the things that keep on triggering a migraine every time. what I see in my practice, weather changes, I hear this a lot, but again, I'm living in North America, where there's a lot of weather changes, a lot of tornadoes, and a lot of storms. So that means that patients actually experience it more. We know that people who live at high altitude, so when they go between, they go to the mountains or they go to different altitudes, different countries, you see more prevalence, only because of these different altitudes and barometric. The weather changes are more linked to barometric pressure changes. Flights, long car trips, wearing hair in a ponytail. And that is something that I was like, oh, if it's this simple, then why do you put your hair in a ponytail? And obviously, most people try to avoid it, but if you have long hair and it's bothering you, there's allodynia as well. There's a lot of reasons why people still would do something that they know is a trigger. Avocados, that was one of the first ones that actually I thought was very weird. Loud noises, certain smells, citrusy food, lemon, lime, all food that tastes different sometimes does trigger certain spices, sunlight, rain, and the one that that really I thought was very weird, white plates. If they eat out of a white plate, it actually triggers a migraine. And one of the things you might say is, oh, is it really a trigger? And the answer to this is, if it's the trigger for them, just make sure that we do not tell them, no, it shouldn't be a trigger, because that's how they feel. And we don't know still why these triggers. We know some triggers, we know the pathophysiology of the disease that is related to some triggers, but we really don't know enough to say, yeah, this can be a trigger or not. Accept it, and let's find ways to deal with it. So why do we need to identify triggers? What is the value of identifying triggers? And there's something called threshold theory. And that means for you to have a migraine attack, you need to reach a certain threshold. And if we're able to reduce these triggers, possibly you will not have the attack. And it's like a cup that overspills. So if you're stressed and there's going to be a weather coming and you didn't sleep well, and then you skipped a meal, you had a drink, then most probably you're going to have an attack. The value of identifying these triggers means that we're going to find the ones, like if I know that all of these have happened already, I don't skip a meal. And that means that I still am at the tip of the cup, kind of. And this is what threshold theory is. So let's talk about lifestyle changes and migraine. Can you really control migraine with lifestyle changes? And a study that was a prevalence case, a reference study that was published in 2016 in the Journal of Neurology. They looked at lifestyle interventions and they saw the impact of regular lifestyle behavior in migraine. And they found that the number needed to treat. So remember the NNT that we studied in universities, like if you have, how many patients do you need, or how many interventions, how many patients get the same intervention, how many of them respond? And the number needed to treat here was 2. And I don't think we have any medication at this point of time that is in the NNT2. So this is the best thing that you can do for someone living with migraine. And that is initiating and having the discussion around lifestyle changes. So 2 meaning of every 2 that had lifestyle changes, 1 of them had benefited from that intervention and showed improvement in the migraine. What this means is that taking a proactive, don't wait until you have a migraine, be proactive and multimodal approach, and that is do more than one thing. Have the medication, have the abortive medication, have the preventive, do the supplements, and have lifestyle. All of these alongside positive lifestyle changes definitely will help. And do not say avoid triggers. And that's what we still say this in our practice. We say avoid your triggers. Instead, encourage positive lifestyle changes. The best way to communicate to other healthcare providers and to also communicate to your patients is to use Seeds for Success, which was actually a great content. That was, I have the reference here, please go. It's a big document that is very easy to follow, but also is very detailed in what you can do in each of those. So Seeds are the mnemonic that we use, and Seeds stand for sleep, exercise, eat, diary, and stress. So if you remember these, and if you try to address these, you've basically covered most of lifestyle changes that are needed for people living with migraine. So I start with S, and S for sleep. And the advice I'm going to give here is not only for people living with migraine, it's for all of us, because we know sleep is one of these things that affect all our lives. So we know that migraine is associated with there are a lot of comorbidities that are associated with migraine, and sleep comorbidities, including sleep apnea and insomnia, are one of these comorbidities, or some of these comorbidities. Poor sleep itself has been described as a migraine trigger. So we know it's a trigger, but we also know that people living with migraine also have interrupted sleep because of the pain sometimes, because of the interruption, because they're too tired. Some of these medications, once they take their medications, they feel sleepy, they fall asleep during the day, they don't sleep well at night. So there's a lot of interruption in sleep and migraine. But we know that people who do not have regular sleep, people who have shift work, nurses have higher incidence of migraine. We know doctors report more migraine. We know people who work with shifts, security, any of these professions that have interrupted sleep and have lifestyle or a career that does mean that they do have sleep interruption, have higher risk of migraine, and they have higher, poorer migraine management. And they have poorer lifestyle habits as well, because that increases their stress, increases their lower socioeconomic status, more mood disorders. Behavioral modification for sleep hygiene can convert chronic migraine to episodic migraine. And this is the one that I thought was like, so if you intervene with sleep, if you are able to improve sleep, do you really have an impact on migraine? And one of these studies actually showed that you can. People who lived with chronic migraine, once they had modification and behavioral modification for sleep, they were actually transferred from, or they were changed from chronic migraine to episodic migraine. Now, remember, sleep apnea is one of these conditions that is very easy for you to find, very easy for you to fix. And if you fix that, then you will see, especially with people who have chronic daily headache, where they wake up with chronic daily headache, they're tired, they are really not sleeping, you can tell that there's sleep apnea, or you think that sleep apnea might be contributing. I love this tool. It's called Stop Bang, and it is available at stopbang.ca /OSA screening PHP. So you just put, it's a yes or no. Do you snore? Are you tired when you wake up? Has anybody seen you or observed you stopping breathing during your sleep? Do you have hypertension? What's your body mass index? Are you over 50? And your neck circumference, and then gender. If you answer these, it's an online screening tool. You click it, and then it tells you what the odds are of someone having sleep apnea. So the first thing you need to do is definitely try and exclude sleep apnea from your diagnosis. Good sleep hygiene. We all know that we can do better with our sleep hygiene, all of us. These are general sleep hygiene let's say ideas that you can share with your patients. And the first thing is definitely avoiding excessive intake of caffeinated drinks. Restrict in the evenings, and caffeinated drinks are not only coffee. You know that tea also has caffeine. We know that a lot of carbonated or drinks like Pepsi or cola or whatever, they do have caffeine. very, very common now to see a lot of people having these caffeinated drinks because they're energy drinks and they're supposed to be healthy, especially if they go to the gym. Sometimes they do not know and they think that it's only rehydrating solution, but sometimes they also have caffeine. So be very detailed in taking the history of your patients, find out what do they drink and make sure that you restrict caffeine. The bedroom, I'm going to say bedroom protocol is a big one in sleep hygiene. The first thing is definitely the room needs to be quiet, dark, and cool. If you cannot have it dark, make sure that they have a sleep mask or find ways to actually make sure that it is quieter. We do know there's some white noise machines or just things in the background to help people fall asleep. Sleep, too little sleep, and if someone has too little sleep and they oversleep, they think that the migraine will go away. That's a myth. Too much sleep is as bad as too little sleep. So make sure that they have a routine where they go to sleep every day at the same time and they wake up at the same time. Most of my patients again say that sometimes on the weekends they oversleep because they're tired from the weekend and they wake up with the worst migraine, or it builds up during the day. And we know we have let down migraine that is reported for people who have very stressful jobs. As soon as the weekend comes, they have the worst migraine ever. And some of it is related to sleep, so make sure that you address sleep. Your bed should always be and should only be associated with sleep. You don't eat there, you don't even reading, try to read in your living room. And when you go to your bed, make sure that it's associated with sleep because it makes it easier to fall asleep in bed. If patients are unable to fall asleep within 20 to 30 minutes, they should get out of bed. I know I'm as guilty. If I'm not able to sleep, then I stay there and I try harder and harder and harder. Make it a point that within 20 to 30 minutes, they need to leave the room and then they come back, try to read, do a cup of herbal tea or like chamomile or something to just calm you down. And this way the bed will not be, or your bed will not be associated with frustration and anxiety. Phones, tablets, TV, blue light, we all know about that, other than the excitation that comes with all these new apps that you cannot stop. Sometimes you cannot stop because it is actually designed for you not to stop. So make sure that you avoid them in bed or in your bedroom. E is for exercise. And remember, in the ICHD criteria for migraine, avoidance of physical activity is a main characteristic. Low levels of physical activity are associated or a sedentary lifestyle. But if someone is in pain, and you tell them you have to exercise, there's a big chance they will not be able to because they're in, like, it becomes a little bit, this is one of the most difficult for me to actually counsel on, and that is E for exercise. However, in 2 studies of migraine, we found that exercise benefits were equivalent to those of migraine preventives, such as amitriptyline and topiramate. Combination of a preventive alongside of exercise was more beneficial than exercise alone. So the best thing is that you do provide a preventive and you encourage exercise. Some patients, as I said, will identify it as an exacerbating factor in migraine. By definition, avoiding exercise is one of the things that we identify migraine with, or that we link to migraine. These might not work. You'll not be able to have them to start the exercise without actually making sure that they have the right preventive. And abortive as well. If a patient is not able to exercise, try to start with even once a week, shorter time periods, and then do low intensity exercise and intervals of 20 minutes. Do not make it exercise that is like aerobics. Go for something that is very aerobic. The best is actually cardiorespiratory exercise. And again, another study that said that jogging, walking, cross-training, and cycling were done for at least 6 weeks for 30 to 50 minutes, 3 to 5 times a week. and they found that this is when you get impact. It's not only that they need to start, make sure that it's small, and then they add to that. The next letter in the mnemonic is E for eat. And of course, eat is food and drink. And we all know I'm one of these people that every time Ramadan came, I knew that I was going to have a headache. So we're not talking only about the headache, we're talking about migraine. We're talking about the headache also starting as a headache because you missed a meal or you're hungry or you were fasting. And that because of the predisposing migraine tendency of a patient that goes into a migraine. 57%, and alongside that, 27%. What's the difference between missing a meal and between food as a trigger? Missing a meal might actually be interfering with your blood glucose levels. It's also dehydration. There's a lot of, it's different from food triggers, because food triggers or food being reported means that it's something that they drink or they eat, and as soon as they eat it, it triggers a migraine. The one I hear, again, as I said, I have citrusy food. I heard about avocados, hot dogs. One of the things was MSG in Chinese food, and that was a little bit conflicting. It's not for us to say which ones they are. Our jobs as healthcare providers is to help patients actually identify what these triggers are. And we need to work with them to identify them. Like, again, caution that triggers are different from cravings. For years, we were telling patients do not eat chocolate because chocolate might trigger a migraine. And now we know it's a craving. It's one of these 48 hours before a migraine, some of these premonitory symptoms that we see with people living with migraine. I think all of you have heard of all the popular diets that are out there. I know that the one that everybody I know on is now keto and intermittent fasting. We know that intermittent fasting might actually trigger, so we do not recommend it for people living with migraine unless they have the migraine under control, and then they can start working with migraine diets or with diets that are different. Keto, we have seen some initial studies that said that going keto will help with migraine, but we know that this was not maintained. So it starts, and it might be because they lose weight with keto, and they limit a lot of food substance and, you know, blood sugar fluctuations, but that was not maintained and that was not sustained over time. Elimination diet is the one that is very popular, and they call it the headache diet. And that is, they start by eliminating everything and then introduce one by one different types of food. And then they have a diary and they record, and they're able to see if there's something. I think it makes sense. It needs a lot of work from the patient, and they need to work with someone to help them. Gluten-free, we know a lot of comorbidities, lactose-free and gluten-free. We know there's a lot of IBS and GI comorbidities are very common with people living with migraine. Low glycemic, vegan. The one I really like is high omega-3, because we know there was a BMJ article that was published a couple of years ago that said high omega-3, low omega-6 is a very good diet, and they were able to show that there is benefit. So the best advice you can give on food and drink, definitely hydration is the number one. And this one makes me worry a little bit when I say it's number one, because most of my patients keep on complaining that every time they tell someone I have a headache, they tell them drink water. And it's not as simple as drinking water. We're saying, what else can we do? It's that threshold theory. Make sure you're hydrated. And one study said 4 liters per day. We know that we need 1.5 to 2 liters, but one study showed value in as much as 4 liters. I also tell my patients, make sure that you also have electrolytes, not just water. Make sure that you are not restricting a lot of sodium and a lot of that you're not restricting also electrolytes in your diet. Regular meals is something that is very important. Do not skip meals. Make sure that you have regular meals, you have snacks throughout the day. Breakfast is something that is always missed, or is something that we all are can do better with. Try to have breakfast within 30 to 60 minutes of awakening, and this can be linked to the next one. Replace your simple carbohydrates with protein, fat, and fiber. And that within 30 to 60 minutes from waking, make sure that you have your biggest protein meal of the day. If you can have an egg or if you can have a smoothie that is protein rich, that's a great idea. Fat and fiber is also very good for you. Limit caffeinated drinks, as I said, increase omega-3 and reduce omega-6. We know omega-3 is anti-inflammatory, while omega-6 does cause inflammation. Increase gut microbiome health, and that is try to get probiotics, prebiotics, fiber in your diet, and always focus on positive change instead of avoidance. Like add natural anti-inflammatory food. Do not say avoid, but replace and start might actually have better uptake from patients. These for diary, and we know keeping a food diary is very important, but a food diary is not only to identify food triggers. There are a lot of apps that are coming up for a headache diary. Is something that is very crucial for someone. If you're the primary healthcare provider that you've seen the patient, or if you are a neurologist, a headache diary is something that is very, very useful. It also helps people feel that they're in control. They can see, they can intervene, and they can see if changes that they do will actually have an impact on migraine. We know that electronic diaries are very, very popular now. I know a lot of my patients do use apps, but I have a lot of patients that say, I want a paper one. And we do have printable ones that are available online. You can just download it from online, and you ask them to put it on their fridge and just do an X for number of attacks that they have or the day that is good. Very simple ones are more likely to be filled than more complicated ones. S is for stress, and who doesn't know that stress is bad for you? There's a lot of things that we can do for stress, and behavioral management is the number one. But cognitive behavioral therapy has been shown to be most important in managing migraine and in supporting people with migraine. Catastrophizing is something that I always see with people living with migraine, because they are very worried about what people will say, what will happen. Am I gonna be affecting someone else? So catastrophizing, I'm gonna have a migraine on that important day, I'm not going to be able to go. Or if I've just apologized to an event or to an invitation, then I'm in their head, they start thinking, oh, I'm never going to be approached again, or I'm never going to be invited again. And the most important thing is to try and work with them to try and manage these catastrophizing ideas, and to try and decrease them and decrease the disability that is associated with migraine. Either in one-on-one, cognitive behavioral therapy is one-on-one, or it could be also in group therapy, and the effects actually are most experienced after 5 weeks into treatment. Biofeedback uses behavioral techniques with physiologic autonomic measures, and this has been extensively studied and does show benefit in migraine. Mindfulness, it's like everybody now hears about mindfulness. We are talking, like I hear mindfulness in everything, and that is to be in the moment and to be aware of the thoughts. Do not dismiss your thoughts, and do not dismiss or judge what you're feeling as this is bad, I shouldn't be feeling like this, but acknowledge them, acknowledge the thought, and that helps reduce the stress. If I say, yeah, I'm upset or I'm disappointed, but it's okay. It's something that is not bad. I'm not doing something bad by acknowledging and being in the moment, enjoying that today, the good days are good days. Enjoy them, live in them, instead of worrying about the other days that you will not be able to do things. Relaxation techniques, again, can be either done alone or can be done with other techniques. They are based on deep breathing, muscle relaxation, and the best thing is to actually combine relaxation techniques and help patients develop the skills. You start with working with a professional, but then be able to progress to do this on their own. In conclusion, when we talk about seeds for success, Remember, seeds is sleep, exercise, eat, diary, and stress. Sleep, standard sleep hygiene recommendations are very important to maximize sleep quality and quantity. Exercise, the aim is to reach 30 to 60 minutes, 3 to 5 times per week, but can be as much as 20 minutes once a week, progressive, low impact, and then you build up. The value that was seen with exercise was not with how much exercise, is how much more you're able to do over time. And that is not only for people living with migraine. We know the best value of exercise comes from how much more can you do over time. Eat regular meals, adequate hydration, and low or stable caffeine intake. I always get the question is, how much caffeine is good? How much caffeine can people take without actually it affecting their migraine? And can I stop caffeine? Because we have this cold turkey, how do I stop caffeine? Do not stop suddenly, because you will basically risk a rebound similar to medication overuse headache. It can have the same characteristics. Start slow, say reduce by half a cup, 2-3 days, then another half a cup. And the idea is that you need 1 to 2 cups per day. That is not seen as, it might not actually become something that affects migraine. It will neutralize the effect of caffeine. Unless it's a trigger, then obviously you try to take it out. People who know that it's a trigger don't usually use it. Smoking is something we didn't talk about, so also reduce smoking, make sure that patients are supported to stop smoking. Diary, a baseline pattern is very important. Again, if you're in primary health, if someone is going to go see a specialist and they go with a diary, it makes it much easier for the specialist to actually give better advice. And then stress, cognitive behavioral therapy, mindfulness, relaxation, biofeedback, and provide the patient trust to minimize anxiety. If your patient trusts you, they're going to be absolutely more likely to accept advice from you. I'm going to talk about pharmacists because I'm a pharmacist and that's what I do. Just remember that we are available, we are accessible. You don't need an appointment to see a pharmacist. So encourage your patients to go talk to a pharmacist if they do not have immediate access to their family doctor, to their specialist, at least to triage if there's a need for triage. Migraine is a neurological disorder and there are a lot of comorbidities. So do not only look at migraine, look at the human being. Treat this as a person, not a disease. Migraine presents in the community pharmacy for different reasons. People come to the pharmacy for OTC, supplements, or prescription dispensing. These are excellent intervention points for education, for support, and for building trust with the patient. Lifestyle discussions are very often overlooked by specialists, and that is not because they don't want to do it. Everybody wants to talk to a patient about how else they can improve their lifestyle and manage their migraine, but there are time restrictions, and there is expectation that other allied health professionals like family physicians, nurses, and pharmacists will be involved in migraine management. It takes a village. It's not, when we said it's multimodal, it's also multidisciplinary. Not one person is enough to manage and support people living with migraine. This is a condition that can be a lifelong condition. In terms of resources, as you know, with the Association of Migraine Disorders is an organization that aims to educate, support, and advocate for people living with migraine. They have resources for patients that you can just print out and give to your patient, but they also do have educational resources that are for healthcare providers, and you can see these. We have a webpage that's only on migraine triggers, migraine treatments, migraine diary, PDF that I talked about how you can actually print it, that is available. Migraine safe foods blog, people talk about safe foods, and 5 lifestyle changes for managing migraine is a podcast. And if you have the time to listen to podcasts, I think the Association of Migraine Disorders migraine podcast is the best out there, for not only for patients. I listen to it. They have also a migraine minute that is only 1 minute about the latest in research. So if you're interested, that's a great resource. if you're a pharmacist, the Ontario Pharmacists Association in Canada has just released a training program, a Canadian CE or CME training program that you can take. I think it's open for everybody. Anybody can take it. You can go register and you can actually know more as a pharmacist. I know that, again, there's a lot of organizations that do provide free of charge education that's open for allied health online. My final thoughts on lifestyle changes is that remember that you're not the one who's going to apply these changes that we're talking about. Patient needs to be willing, and they need to be accepting, and they need to be trusting that you have their best interest, that you're not trying to sell them something or give them one extra pill, that they need to feel that you're supporting them. And the changes required are not easy. People are living with disability and they need to be introduced very slowly, one at a time. And the best thing that can be done for people living with migraine is to provide them with the best management strategy, whether it is with a medication, with prevention, with abortive that actually works, with reducing side effects and making sure that they have the best dose and the best medication and the best support, and listening and hearing them out. Thank you. Empowering patients is something that I'm really very passionate about, but also I hope that this helps you in your practice or day-to-day practice in talking to patients about triggers.
Thank you, Dr. Hiba, for these nice lectures. Actually, we have a lot of questions. The first questions, Doctor, from me. Is there any difference between migraine triggers for patients suffering from episodic migraine headache or chronic migraine headache?
Chronic migraine headache triggers become a little bit more difficult to actually identify. Usually patients do not wake up and they're in chronic migraine, it progresses. So with time, they're able to identify their triggers. But there are also changes in what triggers a migraine. If someone does have migraine previously and they used to have certain triggers, with time they might change. So there is a difference because, number one, it might be with chronic migraine, there's more days with migraine that they're not able to see what they did different that day. Okay, the second thing is, again, the changes in triggers, because triggers do change all the time. Just because someone used to have triggers by, let's say, by their menses, let's say, or their period, it doesn't mean that that stays the only one, because then when you go to chronic migraine, there's 15 or more days per month that you have the headache. And also of these 15 days, there's also different types of headaches that are involved in chronic migraine. So of the 15 days, 8 are attributed to migraine, the others are general headaches. So the idea here is the more aware patients are of what's going on, the more they are empowered to look and to record and to listen to their bodies, the easier it is to identify migraine triggers. I have patients who say, I don't know what my triggers are. And they've lived with migraine for 20 years. They say, I don't know.
Okay. For this, I want to ask this important question. Is there any common unusual migraine triggers?
I tell you, I thought the white plates was weird. I was like, what do you mean you have a trigger if you see a plate that is white? So they need to eat in plates that are colored, not white. Like that was really weird. That I've never heard of, but it's reported, it's recorded, and patients say that unusual. There's a term that I'm really, I'm Middle Eastern as well. I was trained in the Middle East. And if a patient comes and tells me something, it's like, no, that's not it. Or if they explain something, I used to be, I have to admit that I was one of those that said, no, I would dismiss it and say, no, focus. You need to do 1, 2, 3. Okay. And the new science or the new way of doing medicine, I think, is do not gaslight. If someone says this is what triggers, then, okay, what are we going to do about that? Just acknowledge that this is their feeling, this is their experience. I cannot tell. I don't have migraine. I can't tell what happens. So if someone tells me, you know, I need to I need to go on the floor, put my head on the floor, and I feel better because it's cold, I can't tell them, no, you have to go to bed. This is what makes them feel better. Acknowledge and advise them that they are the best experts on themselves.
Yes.
Like, I'm not the expert on someone else.
Yes, sure. I have here interesting questions. Do you check the vitamin levels on blood samples for your patient suffering from migraine?
So interesting. This is a very interesting question, because we know that for people living with migraine, the first thing I do, I start them on magnesium. Okay. That's the first thing I do. And why do I start them on magnesium? It's because we know from clinical trials that supplementing with magnesium is a very good, does have preventive and abortive properties. The only problem is you cannot measure it in the blood, because in a migraine attack, it is intracellular magnesium that is depleted. So how are you going to test this? It's not, sorry?
Even in the CSF?
So how is it, are you going to do lumbar puncture to see I would err towards, I would err on the side of giving them a supplement than to give them a lumbar puncture. I'm not a doctor. Okay. I'm not in, I don't do lumbar punctures. I don't do CSF testing. What I try to do, I'm going to err on the side of, let's give them the supplements. If they get better, perfect. A lot of my patients also live with GI. As I said, GI is a very common comorbidity with migraine. And then I think when I talk about magnesium and supplements, I ask them, do you have a bowel movement? Do you have constipation? Do you have diarrhea? And then choose the magnesium. And sometimes it helps with, even if it doesn't help with the migraine, it helps with the bowels. It helps with muscle pain, with muscle spasms that a lot of my patients feel. It helps when they have spasming around their period. So we talk about supplements in a way that is supportive. Again, I do not do any blood tests. I know a lot of, we do tell everybody take vitamin D, everybody, because we live in North America. If I show you my window now, it's 11 or 12 noon and there's nothing, there's only snow. So that means that the best thing I can do, again, I'm gonna err on the side of supplementing. We do B2 as well for people living with migraine, and we even go for CoQ10 because we have good evidence that it might help with the inflammation. But we know that not all migraine is inflammatory anyway.
Okay, thank you, Dr. Rahiba, for this nice and lectures. Now we will move to our the next speaker, Professor Naji Riashi. It is my honor to introduce my colleague, my friend, Professor Naji Riashi, who is well known. He was born in Beirut. He got his MD from American University of Beirut. After he went to States, spent 4 years in research fellowship in neuropharmacology and neurochemistry in Case Western Reserve University in Cleveland. Then 2 years in Cleveland to get his fellowship in epilepsy in clinical neurophysiology. He had got the American Board of Neurology and Psychiatry, in addition to the Board on Epilepsy in clinical neurophysiology. Recently, he is in Abu Dhabi, UAE. He joined Sheikh Shakhbout Medical City as a consultant neurologist. In addition, he is a clerkship director of neurology and assistant dean for clinical affairs in Khalifa University. Dr. Professor Naji, the floor is yours.
Thank you, Muhammad, for this kind introduction. And I'd like to also thank IVPN and the Association of Migraine Disorder for allowing us to give this talk to you tonight, and our sponsors, Pfizer. Thank you all for staying with us. It's becoming late here in the UAE. It's almost 9 p.m. So I'll try to be as brief as possible. So what I'm going to be talking to you about tonight is the topic of Remigepant, which is a new Japan that was that hit the market. It's approved here in the UAE, and it's a medication that will be helpful to your patients because it will have both a role in acute migraine treatment as well as in preventing migraines. So, as I've mentioned, there is this medication, which is given in a dose of 75 milligram over the course of 24 hours, can be used for treating migraine acutely, as well as for treating migraine and preventing it. So the medication is usually given on an every other day basis, but patients have a leeway to use 3 extra tablets if they want to during the month, so they can take up to 18 tablets per month of the medication when needed. So what is the characteristics that make this such a great medication? First of all, it comes in a dissolvable tablet that will be very fastly absorbed. It will not need water for you to take it, and it will reach the peak concentration very quickly because of that. And then it will give you a very quick effect. And if you take it repeatedly, within 1 week, you will start seeing prevention occurring as well. When you take it acutely, within 1 hour, as I'm going to show you later during the talk, you will get complete freedom from the pain, hopefully. And it's an effect that is going to last 24 to 48 hours, and it will lead to a reduction in the mean migraine days, monthly migraine days in patients that have taken this medication repeatedly. Now, this medication will thus allow you to treat migraine both acutely and preventively. What would be the problem with the medications that are being used so far? So the value of the medications that are used traditionally for acute treatments. Why do we have a need for new medications since those were already available? Well, several. The first of them is a tolerability issue, because when you take the traditional acute treatments, there is a large percentage of patients, about 43% of the patients, that will experience adverse events, and this early on in the treatment. Within 24 hours of taking the medication, they will feel a problem, something will happen to them that will be detrimental to the use of these medications later on. Second of all, these medications do not control headaches well, and there is up to 80% of the patients that will experience a recurrence of the headaches, or the headache will recur within 24 hours, and they will need to take additional medication to deal with these recurrence, which might lead to the formation of medication overuse headache, which is a very difficult condition to treat, and a source of lots of headaches for us that are headache specialists, because many a time we need to admit the patients to the hospital to be able to get rid of the offender or of the medication that is being abused, and treat those patients with IV hydration and other means of treatment to be able to get rid of the overuse headache. In addition to that, a large chunk of the patients that would be candidate for this medication are not able to take it because of cardiovascular contraindication, because these medications, for the large part, cause vasoconstriction, and so they will lead to ischemia and heart problems in patients that have cardiovascular risk factors, so they will be contraindicated in those. And this will represent in the United States alone 2.6 million patients that will not be candidates for these medications because of that. Oops. Okay, so now what would we want from a medication that would be used to decrease the headache? So what would we want it to give us? First of all, sorry, move too fast. I need to go back. Yeah, so we should have a rapid effect, and the effect should be consistent and should always work. We should always be able to rely on this medication to free us from the pain. And not only that, but to also free us from the most bothersome symptoms that are usually associated with the migraine, namely nausea, vomiting, sensitivity to light or sound, sensitivity to movement, because those are as impairing as the pain is, and they will not allow us to function. So if we get rid of the pain, but we're still vomiting our guts out, or if we cannot sit in a room that is illuminated or hear people talking, then we're not going to be able to be functional again. And this is another important criteria that we need to look into, which is the restoration of the ability of these patients to function, which will really lead them to become productive again and will decrease the cost of this medication. And we don't want recurrences, because we don't want to have to use rescue medications over and over again and run into the potential problem of medication overuse headache, as I've mentioned before, and decrease the use of the resources and decrease the cost of using these medications together with a very good tolerability, so minimal or hopefully no adverse events at all. What is really also not very much known amongst you about migraine is that it is underdiagnosed and it is undertreated. And we really think that all people with migraine should be offered a trial of an efficacious acute treatment that will make them feel better and that will get rid of the disease. Now, what about the various factors that we may need for preventive treatment of migraine? Patients with migraine should consider preventive treatment when they have a lot of disability because of the migraine per month. So if the attacks will significantly affect their function, their activities of daily living, their routines, despite the acute treatments, then they should be candidate for preventive treatments. And we've all used those in the treatment of our migraine. And in some patients, it has worked, but in most patients, it has not, because of associated two things: lack of efficacy on the one hand, and on the other hand, when we reach the doses needed for this medication to work, we will encounter a lot of adverse events, and I will discuss these further in a minute. So these patients should be experiencing 2 or more headache days per month. And if they are disabled enough, they should try the preventive medication, sometimes in combination with the acute medication. And we should not wait for the acute treatment to fail to start patients on preventive medication, so that they don't end up going into overuse of the acute treatment, and they don't experience tolerability issues with the acute treatments as well. So the goal of the preventive treatment is, on the one hand, to reduce the frequency of the migraine, on the second, to decrease the intensity of the migraine, and then thirdly, also hopefully reduce the formation of overuse of acute medication, which will lead to medication overuse headache, and which will shift patients from having episodic migraine to chronic migraine, because we know that the cost associated with treatment of chronic migraine goes sky high compared to the cost of episodic migraine, and they are much harder to treat, and they are linked with much more disability. However, the medications that we had available to use as a prevention would really fit the motto, start low and go slow, because we would start with low doses of the medications, and then we would build up with time gradually, because lots of them are associated with fatigue, with cognitive issues. The patient will feel blurred, they will feel that they are not as reactive as they should be, and some of them will also lead to depression. So sometimes we need to titrate these medications over the course of months, up to 6 months, before we can reach the dose that will become efficacious enough to carry the preventive effect in the patient. And in a lot of patients, they will not be able to put up with this long time, and they will stop taking the medications. And also, the patient's preference sometimes would be an injection in order not to take tons of medications, while some others would prefer tablets over injections, especially in the patients that have needle phobia. So we would be left with a big chunk of the patients that would not tolerate or not put up with the side effects of the preventive medication, and that would quit taking them. So now, if we can have a medication that can do both, treat the acute phase of the headache and prevent further headaches from occurring, of course, this medication will be likely to be preferred by our patients, because you would be hitting 2 birds in 1 stone, and you would not be taking multiple medications, especially if you need to take this medication on an every other day basis rather than several times a day, like, for example, would be the case with the beta blockers for them to be functional, or with some of the anti-epileptic medications that are taken at least on a BID basis as well, or twice a day basis, for them to be active. So if we have a medication that can be used for both acute and preventive treatment of the migraine, then that medication would certainly be reaching the patient preference. And with the Nurtec or with Rimegepant, we have such a medication. And I'd like to point here that no other medication has been previously approved by the FDA for both the acute and the preventive treatment of migraine. So we are here in face of a very unique product. Now, as I've told you before, lots of patients would be placed on triptans as an acute treatment to try to get rid of the migraines. But we know also that about 55 to 82% of the patients who have used triptans will discontinue them. And why is that? Because there is a largely unmet need, and these patients will not be happy with the triptans for several reasons that will lead to them discontinuing the triptans. In 40% of the case, the patients will experience adverse events. In 33% of the case, the triptans will not work properly or consistently. And in 27% of the case, the triptans will be contraindicated because of the presence of cardiovascular problems in the patients that will not make them candidate to be using triptans. Now, the acute treatment unmet needs, well, about 15 to 25% of patients, US patients that have migraine would be eligible to be tried on these new medications. And those would be, mind you, patients that have been diagnosed. They have gone to a healthcare provider, they were given the diagnosis of migraine, and they were given a medication that is migraine-specific treatment, but they would have either failed or stopped or have a contraindication to the use of triptans, for example. We know that triptans were recommended as first-line pharmacotherapy for the acute treatment of moderate to severe migraine. But despite that, only 37% of the patients were shown to be using a triptan, and only 16% were current users. So as I've told you at the beginning, migraine is not only underdiagnosed, but it is as well under treatment. We're not giving these patients their fair share of a medication that might be extremely efficacious and beneficial for them. So much so that in 2019, the American Headache Society wanted to address this unmet need in migraine and recommended to consider novel acute treatments in patients that either had a contraindication to the use of triptan or who would have tried the triptan but failed to respond. And this would be a failure of response to at least 2 oral triptans. So unfortunately, we would have to still go through the game of trying triptans and failing triptans before we would finally give patients a medication that would be more effective or less likely to be associated with side effects. And about a quarter of the patients with migraine were found in the US alone to be eligible for this treatment, this novel treatment with this new acute medication. So a word about medication overuse headache for those of us who are not neurologists and who might not be very familiar with it. Medication overuse headache occurs when there is exacerbation of a pre-existing primary headache. So you have to have a headache that will be made worse because of an overuse of a certain medication that you would be taking. Okay, and so to decrease the risk of developing medication overuse headache, one would have to limit the intake of medications to either 10 days per month of a traditional migraine medication or 15 days per month when it comes to the combination of acute medications or simple analgesics that are combined together. So the best treatment for medication overuse is to stop the medications that's being overused. But this is, as I've told you before, easier said than done, and very often we need to admit these patients to the hospital and start them on IV hydration, IV medication. Sometimes I even give them steroids to be able to get rid of the offender medication, because it is very, very hard to get rid of it, and it's really not easy to do. In addition to that, lots of these patients end up developing chronic migraine. About 69 or 70% of the patients with chronic migraine had gone through the phase of becoming acute care medication overusers before they shifted from episodic to become chronic migraineurs. And when it comes to triptans, they are more likely to be associated with that, because you can become a medication overuse headache faster when you use triptans by 1.7 years and with lower dosages of the medication. So this was seen to happen with 18 single doses per month when compared with other acute medications, as for example, the analgesics. Now, how would Nurtec, which is a CGRP receptor antagonist, work? Why do these medications work, and how do they decrease the effect of migraine on patients? How do they stop migraines from being the problem that they are usually? Well, selective bindings of the CGRP receptor antagonist will decrease the vasodilatation. However, of note here is that they decrease the vasodilatation without causing active vasoconstriction, as is the case for ergots or for triptans, for example. And this is why when people are using these CGRP receptor antagonists, if we have cardiovascular risk factors, this would not be a contraindication to their use, and they will not be contraindicated in this subcategory of patient, which is really a plus. As I've shown you before, there is a huge amount of patients that would not be candidate for triptans or for ergots, even more so, because of cardiovascular risk factors. Now, in addition to that, they were shown to inhibit the neurogenic inflammation, the cascade of inflammation with the release of cytokines that will potentiate the inflammation and increase the pain. And they will also block the cascade, because usually what happens is you have the vasodilatation, you will get the release of neurogenic inflammatory substrates that will activate the trigeminal receptors. And then with that, we will get activation of the pain centers located in the brain. And once the pain centers have been activated, more likely than not, you're going to deal with recurrences and with longer headaches, which are going to be much harder to treat. So with the use of these CGRP receptor antagonists, we will stop this completely. So we'll stop the vasodilatation without vasoconstriction, and we will inhibit the neurogenic inflammatory cascade. And this will also lead to inhibiting the pain signal and the deactivation or not activating the pain centers in the brain. Now, the superiority of Nurtec or rimegepant when used over placebo was documented in 3 studies that enrolled altogether greater than 4,000 patients. And they had 2 co-primary endpoints for the studies. The first one was pain freedom at 2 hours, and the second one was being pain-free from the most bothersome symptom associated with migraine: nausea, vomiting, photophobia, or phonophobia. And in those 2 endpoints, co-primary endpoints, the 2 were met and showed a superiority of the response of rimegepant or Nurtec over placebo, and that difference was statistically significant, of course. Not only that, but we also had 21 secondary endpoints that were evaluated, and Nurtec was able to meet 19 of the 21 secondary endpoints, which also is very unique to this compound. No other gepants have that palmarès, if I may say so, of meeting 19 out of the 21 secondary endpoints, which, for example, would deal with pain relief, complete pain relief at 2 hours, which was, again, in favor of rimegepant compared to placebo. And with that, 86% of the patients would therefore not need to take a rescue medication within 24 hours of the dose, which is a plus. This slide shows you some of the secondary endpoints that I told you about. Some of them have their effect immediately within 15 to 90 minutes. Some others have an effect at 2 hours, and some others have more prolonged effects that are maintained for 24 to 48 hours. So pain relief, for example, we start having a response at 15 minutes. It becomes clinically significant at 60. This is maintained at 90 and at 2 hours, and it will be maintained as well at 24 and at 48 hours, which is really superb. The return to normal function, the pain freedom of the most bothersome symptom, etc., all of these also had the same kind of response. Now, this is a very interesting study because this is a post hoc analysis that was done in adults that were taking Nurtec on a PRN basis when they would need it for a long period of time, and they kept on doing that for 52 weeks. And this study initially was done to evaluate the safety of the medication. So it was an extension that looked at the safety of the medication. But when the subgroup analysis, the post hoc analysis was done, it showed that patients were having less and less headaches. So they were being protected from the headaches, and they reached 30% and 50% reduction. 68% of them reach 50% reduction, and even more reach 30% reduction at 52 weeks. So they concluded from that the patients taking rimegepant on a PRN basis for a longer period of time will have a decrease in their monthly migraine headaches, and those were patients that at baseline would have 6 monthly migraine headache or more. And so this led to the company doing studies to show that this compound had a preventive effect. Now, if I want to compare Nurtec or rimegepant to the triptans that are the classical, traditional mean of treating acute migraines, what would I compare and conclude? First of all, as I've mentioned before, Nurtec will have a very early action, and within 60 to 90 minutes, the patient will be able to function again. Their functionality is restored. They would have pain relief, and they would also, very importantly, have freedom from the most bothersome symptom associated with the migraine. And this effect will be maintained at 2 hours and will be even increased at 2 hours, where you will have freedom from photophobia, from phonophobia, from nausea, pain freedom. All of these will be met at 2 hours. And not only that, but this effect will be sustained and durable for 24 to 48 hours. And the same thing will be seen with the long-term safety maintained through 52 weeks. So this does not come at the expense of the safety, or it does not come at the expense of more adverse event. Whereas in triptans, 42% of the patient required a second dose. 67 to 82% stopped using the triptan because of side effects or lack of efficacy. 43% of the patient had adverse events or side effects, including nausea, fatigue, rapid heart rate within 24 hours. And also remember that triptans are contraindicated in those patients that have cerebrovascular conditions. Now, is Nurtec going to improve the quality of life when used for acute treatment? And the answer is yes. It does so by improving the absenteeism or the presenteeism with a problem, because it will get rid of the headache. And it has affected absenteeism by decreasing it by 44%. So we gain 8 days per month. The presenteeism by 43%. So again, we gain about 7 days per month. All of this will lead to less lost productivity time, and we will have about 11 fewer days of less productivity days per month when compared to normal. All of this will lead to an improvement in the workplace productivity, and will start cutting on the cost, direct and indirect cost of migraine, and will lead to a much better quality of life of the patients, of course. Now, when we look at the reduction of the mean migraine days during weeks 9 to 12 in the preventive studies, we're talking earlier about the acute studies. And when we talk now about the preventive migraine with the reduction of the monthly migraine days, we see again a favorable response with rimegepant 75 when compared to placebo, which again reached statistical significance. So the patients that were treated with oral rimegepant had a 4.3 days reduction from baseline of monthly migraine days during weeks 9 to 12 of their treatment, which was extremely nice to have. Now, when we look at the percent reduction of migraine days per week, and we compare this again placebo to rimegepant, as you can tell from your graphs, you have a 30% reduction in the weekly migraine days in the first week of the treatment that was provided by the medication, when compared to 9% for the placebo, which is again another very, very good thing to have. Now, the effect of Nurtec is not only fast, but it lasts for a long time. So in the acute treatment, 63% of the patient taking Nurtec will have freedom from pain at 2 hours, but this effect will be maintained up to 48 hours versus 50% of them taking the placebo. And also in the preventive treatment groups, 49% of the patient will have a decrease of their monthly migraine days by more than 50%, which is one of the means we use to measure the efficacy of the migraine treating medications, versus 41% of those taking placebo during weeks 9 to 12. And this is a consistent trend that will be shown every month for the following months, and it will be sustained as well. Now, as I've told you before, this does not come at the expense of side effects, whether serious or others. There were no serious side effects described with this medication, none, not in the placebo arm and not in the rimegepant arm. The most commonly seen side effects were nausea, abdominal pain, dyspepsia, and urinary tract infection. And as you can tell, there is not such a great difference between Nurtec and the placebo, and this will lead to patient persevering on the medication, and a very small discontinuation rate of 2.7% was seen across the acute and preventive trials because of the adverse events, which is really very reassuring and nice to have. Now, with Nurtec, we have one medication that will offer you the advantage of treating the acute migraine attack, and this would be by taking 175 milligram Nurtec ODT as needed on a PRN basis, usually once every other day. But as I've told you, since you have those 3 extra tablets that you could take it once a day if need be. If you want a preventive effect, you would have to order it on an every other day basis. And 90% of the patients in the clinical studies adhere to this every other day dosing because it will not really cause adverse events, and it will be very, very well tolerated. So the maximum dose in a 24-hour period is 75 milligram. And as I've mentioned before, you can take up to 18 doses of Nurtec per month, because you have 3 extra tablets that you would be allowed to use if need be. Nurtec is sold in boxes that contain an 8-pack of tablets. So if you want to use it PRN, you would prescribe only one 8-pack. And if you want to prescribe it for prevention, you would have to prescribe 2, because the patient would use them on an every other day basis. So this is how you would write your prescriptions according to the needs of the patient and to your plans as to whether you're using this for acute treatment or for preventive treatment. So in short, Nurtec ODT can be used both for the acute treatment of migraine as well as for the prevention of episodic migraine. It targets the CGRP, which is known to be a very important mediator of migraine. In fact, if you inject CGRP into your patients, you can trigger a migraine attack. It will offer early and sustained efficacy to the patients with a very good response at even at 60 minutes, but maintained at 2 hours and also at 24 and 48 hours. It was effective for episodic migraine prevention in adults, and it was extremely well tolerated with the tolerability that was compared to that of placebo. And treating the patients with rimegepant 75 milligram every other day for 1 year was also well tolerated in the studies that were done, and did not lead to a high number of discontinuation with low discontinuation rates noted. With that, I will stop and I will be happy to entertain your question. Thank you very much for your attention.
Thank you, Professor Naji, as usual, top-notch, comprehensive presentation. Actually, we have a lot of questions for you. Are you ready?
Yes, please go ahead.
Let's start. First question, what about the role of diclofenac or NSAID in treatment of acute migraine attacks?
Of course, well, you know, you could treat migraine in 2 different ways. You can go with the pyramidal approach where you start with the least expensive, the most common medication, and then you go up the ladder, or you can decide to go straight to the more specific medication. If a patient responds to non-steroidal anti-inflammatory, that's fine. We don't need to change anything as long as they are not taking them excessively. They don't have any GI discomfort. They don't have any GI side effects, etc. If they take them and tolerate them and they're taking them once or twice a month, fine and good. We don't need to do anything different. However, when they get less than appropriate response to the non-steroidal and you need to go the step further, we used to go to the triptans. And then now, hopefully, we will also be able to use the CGRP inhibitors, as we've mentioned today, and we might have another candidate, which is this class of medication.
Okay. What about the option treatment for acute treatment for patients and women who are pregnant?
Yeah, unfortunately, these medications, according to the label, are not to be used in pregnancy. So we are not advertising using them in pregnant women. And in pregnant women, we are limited, unfortunately, with the medications that we can give to treat acute migraines. Magnesium has been used in some. I agree with Dr. Hiba. So I use magnesium in my pregnant ladies, and then we can use whatever their OB allows, because I mean it is going to be their comfort zone, not mine, that will matter. I tell the pregnant women that come to me with migraine, I tell them, come back to me once you have delivered. In the meanwhile, whatever your OB is fine with, I'm fine with. Okay.
What about during breastfeeding? Japan are safe during breastfeeding?
Again, there is a recent studies that was done on normal volunteer that showed that Nurtec is safe. However, in the label, it is mentioned that it should not be used in lactating women. But we should have more data regarding this soon, hopefully, because these studies are starting to get done.
Like the interferon in MS in the beginning, they were contraindicated in pregnant and breastfeeding. Now we can prescribe this medication in patient and MS in pregnant and during also in breastfeeding without any problem.
And like some of the anti-epileptics that we used to tell ladies not to take when they are breastfeeding, when now we know that they are, at the contrary, they are welcome to take them.
Yes. The next question is about, is our patient starts this new agent, when you can judge if the drug is effective or not, and when should we consider the next follow-up visit?
Well, usually when I give these patients this medication, I give them one box and I ask them to use it during 1 month and to keep a diary, as Dr. Hiba has mentioned. This would be very, very helpful because, I mean, if we have a diary from the baseline, it would be even more helpful because you will have an objective comparison. But usually when patients come to my clinic, I ask them how frequent the headaches are, what's the duration, what's the intensity, when are they functional again, how long does it last, etc. And I note all of this. And then I see them, if I need to use this medication, it would mean that these medications, that these patients are active. So when I get to see them back a month later, I can go through my notes and ask again, or go through a diary if they were kind enough to come back with a diary. And we usually will discuss whether they felt better, whether the headaches were more manageable, less intense, less in duration, less in frequency, whether they were functional or not. And this is how you're going to judge whether this medication has been helpful or not. Now, mind you, as I've shown you, the effect will intensify with months. So in the graphs that I showed you of the patients using them for 52 weeks, they kept on getting better and better until they reached 52 weeks. So you should not judge based on 1 month alone. But I mean, usually you will get an indication even after 1 month of use that this medication has been helpful and has decreased the migraine toll on these patients.
The next question, if the patient is doing well on his preventive treatment, for how long you will keep the patient on the preventive treatment?
Well, I have my own. I treat them the same way I treat pain. So as long as they are still having headaches coming and going, I maintain the preventive treatment. When they tell me that they have forgotten that they had migraines or headaches for 6 months or more, then if they want to taper the medication off, I do it, but I do a very slow taper. I do not stop cold turkey because with withdrawal, I would expect to have further problems. So I do a very slow taper, and as long as they are tolerating that and doing well, we can continue to taper up the medication and to stop them completely.
Any data about chronic use of this preventive treatment, new preventive treatment?
What do you mean by chronic use? We have the data that was shown in the study in which patients were placed on it for 52 weeks. Taken on an on-off basis, and it was very well tolerated. No safety issues were raised, and it was shown to be efficacious and preventive and had a preventive effect in addition to the acute effect.
Okay. The next question, if you have a naive patient presenting with typical features of episodic migraine headache, shall you start him on the old traditional preventive treatment, or you will start with the new traditional treatment for migraine headache?
So it will depend on the extent of disability of this naive patient. I mean, if the naive patient has minimal disability, 1 or 2 headaches per month that are lasting 4 to 6 hours and not very disabling, I might want to try a more traditional, maybe I would even start with non-steroidals. I mean, but if the patient is naive, but it is very disabled, my inclination would be to go towards the more efficacious medications and the better tolerated, because, you know, these patients are, when they come with severe headaches from the get-go, they're not going to do well usually on the simple analgesics.
Okay, next question from William. Any role of herbal treatment or physiotherapy in migraine management?
Of course, I mean, there are a lot of alternative therapy to treat migraine. We have some of them that were already shown at the headache meeting. We have these stimulators band that they put on the patient's head. We have the biofeedback sessions, the therapies that Dr. Hiba has mentioned as well that could be extremely helpful, the relaxation techniques. I mean, there is plenty, the avoidance of triggers. There is plenty that you can do, the lifestyle modification, not let yourself without a meal and become hungry when you know that this could trigger a migraine. I mean, yeah, there is a lot of things that one can do to try to improve the migraine besides medication. Unfortunately, in the large majority of patients, this will not be enough, and we'll still have to resort. And I'm talking about the moderate to severe migraine. Usually, we will not be able to get by with just that, and we'll need to use medications as well.
Thank you. What about association with TMJ disorder and migraine headache?
What about it? What do you want to know about it?
Is there an association between TMJ disorder and migraine headache?
Well, I mean, every kind of headache that could affect the face and the neck can affect migraine, because I mean, it could be one of the triggers. I mean, you never know. There is no direct link between TMJ and migraine, but I mean, if you are constantly bothered and stressed and in pain, that of course could lead to migraines. The same would hold true for some patients. Tell me, I start my migraine with neck pain, and I don't think that this is how it's starting. I think that the neck pain is the trigger, or it is the preemptive, the first sign of the migraine that will end up with a full-blown migraine later on.
Okay. I think this question is answered by you, is dosing and frequency of Nurtec. You answered. The next question, if the patient took the Nurtec and didn't feel good after 24 hours, can he repeat the dose after 24 hours?
Yes, you can repeat. You should not repeat the dose within 24 hours. Within 24 hours, 75 milligram is the maximum dose that you should take. But of course, if they need to take it the next day, they can. And this is why some people end up taking it on an everyday basis for maybe 10 days or 7 days or 5 days, and then they stop taking it if need be. But very rarely do they need to do that, because usually the effect of the pill will last for about 48 hours.
Okay. If the patient starts on Nurtec and has a tremendous improvement, and for financial issue, can you switch him to another old preventive treatment?
We still don't have this kind of, I mean, we don't have the literature behind this question to back it up. What I would do empirically, if they cannot afford the medication, I'd have to play games. But I mean, I don't have a good recipe to give to anyone regarding this. It will really depend on the patient, on how badly they are, or how. I mean, you know, we will do what we can do for those patients, but it would not be, of course, providing the most appropriate therapy, unfortunately, because of the financial restrictions.
The other question, is there a clear algorithm in choosing between the new preventive treatment for migraine, anti-GCRP in Japan?
No, there is none. You might elect to go for any one of the CGRP inhibitors. Now, mind you, the IV CGRP inhibitor has been used in status because it breaks the status. That would be one indication, but other than that, it will depend on the tolerability, the situation of the patient, the preference, whether they have a very active life and they don't want to come back to the hospital on a monthly basis. I mean, it will depend on a lot of things that will have to indicate which one of them to pick.
Is Nurtec effective in treatment intervention of migraine associated with menstrual period?
Yes, it is.
Yes. Questions. How long a patient should use propranolol and topiramate when prescribed as a therapeutic purposes?
If it's working and that person tolerates the dosages that are working for them, then they should use them up until they have complete relief of the headache, as I've mentioned before. However, this combination in particular very often leads to side effects, because patients will feel sort of like groggy, and they tell you that once you taper off the medication, they become awake, is the term that they use again. So it depends on the patient, on their tolerance to side effects or not, on the response that they get from the combo. again, you have to individualize patients. I mean, not every patient will be similar.
We have a special question from Lebanon. Maya, your sound is not clear.
Yeah, I was saying that, sorry for the interruption, but I'm provided with somewhat of messages from colleagues of Rieshe who wants to ask the questions. So one of the questions is from
It is, you are cutting off, Maya.
sorry.
Yeah.
So the one question from Dr. Rami Al-Attar, who is saying hi to you and Dr. Harib, and would like to ask about any data on the or any data or effect for the combination of Nurtec and Erinumab.
Yes, actually, we discussed this in a congress that we had yesterday, and we actually discussed this also at Sheikh Shakhbout Medical City, and we agreed that because we don't have enough data yet on the combination to avoid having any side effects, we would combine the medication, but we would use Nurtec as a acute treatment only, not as a preventive treatment. Because if you have to use it as a preventive treatment, it means that whatever medication you're combining it with is not working. Then you should consider your treatment. But you can use it as an acute treatment instead of triptans if it works much better. Then and up to 8 tablets per month is the consensus that we have reached, and it seems that this is what people in Copenhagen are doing as well, and we're starting to hear from other headache society that seem to adopt the same policy.
And another question from Dr. Wiley, who also says hi for both of you. So he's asking about from your experience, what is the treatment of migraine for children?
Maya, I'm really sorry, but you're cutting off badly. I can barely understand.
Yeah. I will try just to, I'm not sure if it's from the connection.
This is better.
So,
go ahead.
Yeah, so he's asking from your experience, what is the best treatment for migraine in children? And is Nurtec can be used in children?
No, the label does not call for the use in children. I mean, it was used in adults. And again, scientifically, I cannot answer this question because I mean, we hopefully will have the studies done soon. What I've been doing, and this is off-label, and I don't, no companies will be invoked in this. This is completely off-label. This is my own personal experience. I've been treating those people that have reached adolescence, so puberty, as adults, and because I mean, when they have intolerable migraines, especially in young women that have migraines with their menses that are not controlled, I treat them like an adult, and I've administered the medication the same way that I do to adults. But this is my own off-label use of the medication. Once more, I want to highlight that.
Can I just interject? I know Dr. Riashi has mentioned our colleagues in Copenhagen at the Danish Headache Center, where they have said that they're actually trying candesartan in children as a preventive. Even though it's off-label for migraine, it is indicated for children for other conditions, and they seem to initially have good results, but we still don't have studies, we don't have anything to actually support this. But I thought it was very interesting to hear, because candesartan is one of those that also we use in adults, and we
Which
see
dose they are using candesartan, 8 milligram or 16 milligram?
I think you can start with 4.
4
Depending on the age of the child, it starts at 4 milligrams, and you titrate as tolerated, obviously. But it seems that this is something that they have started using, and they have reported initial good results with that. But I didn't see a publication. I didn't see anything.
Okay.
I have a few patients, pediatrics, that I've done the same for. with good result, but it's anecdotal experience only. The numbers are small, and I did not do it in a prospective randomized way. So again, once we're walking on very thin ice here, but it's good to know that it's something that we can use. Hiba, thank you.
Okay, next question, Professor Yashi. Will patient experience withdrawal effect in case of sudden stopping after long-term maintenance of any preventive treatment?
Well, preventive treatments as I've mentioned before, I don't like to withdraw them suddenly. I like to taper them off slowly, and I take my time. I'm in no rush because we're decreasing doses and we're getting rid of the medications. But I believe that I've had a couple of patients that stopped the medication cold turkey themselves. They came back with horrible headaches. So if I were to use this as my baseline landmark experience, I would not want to do it cold turkey. I would do it in a slow taper over the course of months. I mean, I don't even do it over days. I taper it little by little by 10 weeks by 10 days to 2 weeks interval.
Okay. What about tapering schedule would you suggest for preventive treatment for anti-GCRP?
For the preventive treatment, well,
yes, preventive
depending on the medication. I mean, if they are on a beta blocker, we could go a little bit faster. If we are on topiramate or tricyclics, I usually go down by 50 or 25, depending on what the dose is for the topiramate, and 10 to 25 increments for the tricyclics, again, depending on how high we've had to reach. If they need to for other medications, they can send me an email and tell them exactly what I do.
The last question, what about the role of ergotamine in acute treatment?
Well, ergotamines are extremely powerful medication. We used to restrict their use to patients who had failed triptans or who had recurrence to triptan because of the severe side effects that are associated with them, and the even more severe vasoconstriction. It's much worse than the one that we see with triptans, and because of the nausea that is excessive when they're taking PO. But they were very effective, but with loads of side effects that make us shy away from their use. And also, I want to warn against their use on a regular basis because of the ergotism that is worse than the medication overuse headache. I mean, if you get patient hooked to the ergots, that's almost the end of the world. It's very, very difficult to get rid of them, and they are associated with the worst medication overuse and with the worst migraine ever. So use them only if you need to on a acute base, not on a prophylactic base, because at one point in time in Lebanon, we had a medication that had ergots that were used prophylactically, and I had to admit 10 patients with that to the hospital to be able to get rid of the addiction.
Okay. I think by this question we came to the end. Again, I want to thank Dr. Hiba and Professor Najib for this top-notch comprehensive lectures. Now I will lead the floor to Maya to make her final touch concerning this event. And again, I want to thank you, Pfizer, in supporting this medical conference. Maya.
This, our second migraine masterclass comes to its end. And of course, I would like to thank our excellent moderator, Dr. Harib, and our esteemed speakers and migraine experts, Dr. Hiba and Professor Riashi. It's always an honor to have you with us. And also, I would like to thank Pfizer for supporting this educational activities and many more to come. And the big thank you goes for our attendees for staying with us until the end and for this wonderful interaction and all the questions we received. If you would like to revisit this webinar and listen again to the lecture, you can visit our IVPN library where all the presentation will be posted there within 1 week from today. Also, you will receive your certificate of attendance by email. within 1 week from today. Follow us on our social media platform and stay tuned for more activities in the field of neurology. And our third migraine masterclass will be scheduled on February 27. And of course, all these webinars are organized in collaboration with the Association of Migraine Disorders. So thank you for them, also for this great collaboration. Until I meet you again, have a good night and stay safe.
Thank you, Maya. Yalla.
Thank you. Have a very good
Bye.
night. Thank you. Bye.
Bye-bye.
Bye.